thrombectomy, 6 to 24 hours after a stroke with a mismatch between deficit and infarct. Thrombectomy. Thrombectomy, mechanical thrombectomy, or simple thrombectomy, is the interventional procedure of removing a blood clot thrombus from a blood vessels. It is commonly performed in the coronary arteries, peripheral arteries, and cerebral arteries. Application in medicine. Ischemic stroke represents the second death cause in the Western world. Until recent times, systemic intravenous fibrinolysis was the only evidence-based therapy for patients with acute onset of stroke due to large vessel occlusion. In 2015, the results of 5 trials from different countries were published on one of the most prestigious medical journals, the New England Journal of Medicine, demonstrating the safety and efficacy of mechanical thrombectomy with stent retriever to achieve a better outcome and reduce mortality. It is now a widespread procedure performed in most primary stroke centers over the planet, especially in the developed world. Neurothrombectomy procedure. Update. Effects of endovascular thrombectomy that is performed more than 6 hours after the onset of ischemic stroke is uncertain. Patients with a clinical deficit thus is disproportionately severe relative to the infarct volume may benefit percent. Pros: the success rate is high, and most of the cases where treatment is insufficient, it can avoid major surgery, leading risk complications. Cons: availability of vascular surgeon, relative major contraindication in acute postoperative setting, intracranial hemorrhage, major bleeding requiring transfusion, a compartment syndrome, embolization, a revolution in stroke care, thrombectomy.
Time is brain. Think of a stroke as a forest fire. It starts small, it's gonna burn a few trees, and over time it's gonna burn the whole forest. Whatever has been damaged, you can't bring it back. What this mechanical thrombectomy does is you put the fire out, and you haven't really seen anything this big in the care of stroke patients. And in terms of treatment power, it's something that you haven't seen in neurology before. Your chances of being back to normal or near normal is close to 50% with the treatment. If you have no treatment, the chance is just like 13%. You're not getting exposure on, I know what. So essentially what you do is most of the time you go through the groin artery called the femoral artery. We get inside the blood vessel, and then under X-ray guidance you can guide that tube all the way to the neck. We shoot contrast dye, we then can take pictures of the brain blood vessels, locate the site where the blood clot is occluding the main artery, and then you put the stent retriever. They essentially look like a wire mesh, and then the clot gets engaged, integrated in the wire mesh, and then we can remove everything as a unit, and then hopefully the blood clot is completely removed. That procedure can be as quick as 10 minutes to 20 minutes. For the intravenous blood clot buster medication, the so-called TPA. However, because the clot was long and big, it was too big for the TPA to dissolve it. We were fortunate to very quickly remove the blood clot and see this wonderful response that immediately after the procedure he had this. It is again a complete occlusion of the middle cerebral artery, and these areas here, they are responsible for your movement, your motor function, specifically in the face and arm. So the blockage was exactly here, and you were missing out this piece here. So luckily, because you were able to reach
Acute applied echo methods, we roller patients with occlusion of the intracranial internal carotid artery or proximal middle cerebral artery who had last been known to be well to 6 to 24 hours early, who had a mismatch between the severity of the clinical deficit and the infarct. Volume with mismatch criteria defined according to age, left FT years or AT years. Patients were randomly assigned to thrombectomy plus standard care. The thrombectomy group are to standard care along the control group. The complementary endpoints were the mean score for disability on the until-weighted modified ranking scale with range from OD to plain symptoms or disability, and the rate of functional independence as scored 0, 1, or 2 of on the modified ranking scale, with range from 0 to 6, with higher scores indications more severe disability at 90 days. Results: a total of 36 patients were enrolled. 107 were assigned to the thrombectomy group and 99 to the control group. At 31 months, enrollment in the trial was stopped because of the results of a prospective interim analysis. The mean score on the utility-weighted modified ranking scale at 90 days was 50 in the thrombectomy group as compared with 3.4 in the control group, and the rate of functional independence at 90 days was 49% in the thrombectomy group as compared with 13% in the control group. The rate of symptomatic intracranial hemorrhage did not differ significantly between the two groups. Conclusions: among patients with acute stroke who had last been known to be well 6 to 24 hours early and had a mismatch between clinical deficits and infarct outcomes for disability at 90 days were better with thrombectomy plus standard care than with standard care alone.
For patients with acute ischemic stroke, endovascular thrombectomy within 6 hours after the onset of symptoms can improve outcomes. Patients with a disproportionately high NIH stroke score, given the size of the ischemic area on perfusion imaging, so-called clinical infarct mismatch, are more likely to recover function after thrombectomy. The DAWN trial tested whether patients in whom brain imaging showed proximal anterior cerebral vessel occlusion and clinical infarct mismatch would benefit from thrombectomy 6 to 24 hours after the onset of an ischemic stroke. 206 patients were randomly assigned to receive thrombectomy or standard medical care. The patients were then assessed at 90 days after stroke. The primary outcome of post-stroke disability on the utility-weighted modified Rankin scale showed a mean score of 5.5 for the thrombectomy group versus 3.4 for the standard care group, a statistically significant difference. Functional independence was achieved in 49% of patients in the thrombectomy group versus 13% in the standard care group. Procedural complications occurred in 7% of patients in the thrombectomy group. The rate of other adverse events, such as symptomatic intracranial hemorrhage and death, was similar between groups. The trial was stopped at 31 months when a planned interim analysis showed the superiority of thrombectomy. The authors conclude that in patients with acute anterior circulation stroke with clinical infarct mismatch, thrombectomy performed within 6 to 24 hours significantly reduced disability and improved functional independence at 90 days, as compared with standard medical care.